as I'm sure you're aware, and a lot of the audience are aware, HRD is a good indicator of whether patients with high-grade serous ovarian cancer will respond to platinum-based chemotherapy and or PARP inhibitors. And we believe that around 50% of the population have some deficits in the pathway of homologous recombination of DNA repair. And we have up until now identified that population through screening of tissue, which we've taken either at biopsy or at surgery. And that tissue, the gold standard is the Myriad test, which looks at genomic instability using a lot of heterozygosity and large translocation events to actually identify a population that may have difficulties in repairing double-stranded DNA breaks. That's quite difficult to do. There are lots of stumbling blocks. First of all, getting the tissue to the right place. Secondly, making sure that you've got enough tumor in the tissue to extract the relevant DNA. And we found practically that a lot of our patients who have neoadjuvant chemotherapy, we are reliant very much on mental biopsies. And sometimes we don't even get those. We just get an acidic tap with a cell pellet. And sometimes the mental biopsies and the cell pellet have far too little DNA for that assessment to be undertaken. And then the second issue is what changes over time. So we're beginning now to understand that particularly patients with BRCA mutations, you do get some resistance to PARP inhibitors where some of them actually restore the ability to repair their DNA, and therefore they become resistant to further platinum therapy. And it's quite helpful, I think, for us to understand in a bit more of a real time exactly when this is happening so that we can advise patients about prognosis and potentially look for alternatives to manage them. So we've been hunting for a long time for a quicker and easier and perhaps more accurate way of assessing this group, because again, the other pitfall of the genomic assays are that it doesn't seem to quite fit. We still have trials which show us that some of the HRD population don't respond as well as we had thought that they might. An example of this is Paula, where the HRD negative population absolutely did not have any benefit, and yet in Prima and Nova, which is the niraparib one, the wild-type population did benefit. So there's clearly some sort of difficulties really honing down on the exact HRD population. So what we've done here is, instead of taking tissue, we've taken blood samples, and we've just so far taken blood samples from patients with advanced ovarian cancer. We know, because this is a retrospective series, if you like, we've taken blood obviously at the time, but we know their BRCA germline status, but actually the time that we were doing this work, we weren't funded to undertake the Myriad test. So we do know a few patients' HRD status, but the vast majority we don't. But we do know 100% of their germline status. And what we've been doing is we have isolated, well, not really isolated, we've spun off the red cells, and then the cell pellet we put through a fax machine, which tells us that there are lots of cancer-associated cells. So these are cells that have CK7 on the surface. They do not have CD45, so they're not white blood cells. They have nuclei, and they also express WT1, which is a significant hallmark of high-grade serous cancer. So identifying those cells that are WT1 positive, PCK positive, CD45 negative, we've then put them under like a microscopy and stained for RAD51 foci. Now, RAD51 is a key component of the DNA repair process. There are lots of other proteins that are involved in it, but RAD51 certainly has associations with both of the BRCA proteins. And it seems to form when you have good DNA repair via the homologous recombination pathway. So we were looking for RAD51 foci, and we were expecting to find them in patients who were BRCA wild type, perhaps not quite so many of them if they had homologous repair deficiency, because they clearly couldn't repair as well. And certainly we found in our group the 8 patients with BRCA mutations had no RAD51 foci at all. So that fitted with all of our hypotheses. And we then looked at the RAD51 foci in these patients and looked at the outcome of the patients, so the progression-free survival. And what we've shown from this study is that the numbers of RAD51 foci at baseline, so prior to any treatment, seemed to correlate with the progression-free survival. So if you had lots of RAD51 foci, your progression-free survival was not as good as if you had few RAD51 foci. So in other words, you are identifying a population of patients who are less able or unable to repair their DNA via the homologous recombination pathway. And what we're hoping is that if we can scale this up, we will then actually be able to identify these patients in real time so that we can take more blood at certain time points and show or not show, depending on the situation, that maybe their ability to repair DNA has changed. But certainly those that have the significant numbers of RAD51 foci have poorer outcomes, which is, I think, what we would expect.